So this session is on uterine rupture. The key learning points for the session include understanding that uterine rupture is an uncommon but life-threatening complication of pregnancy, to understand that previous caesarean birth is the most common underlying cause, but we'll discuss other causes, to appreciate the importance of prompt identification of the problem, early involvement of the multi-professional team and timely escalation to seniors, to consider expediting birth of the baby, ideally within 18 minutes of suspected uterine rupture for better neonatal outcomes, and to understand that complications include hemorrhagic shock, perinatal morbidity, and complex postnatal care. So what is uterine rupture? Uterine rupture is defined as disruption of the uterine muscle extending to and involving the uterine serosa, or disruption of the uterine muscle with extension to the bladder or broad ligament. It is associated with bleeding, fetal compromise, and expulsion of the fetus or placenta into the abdominal cavity. And how does it differ from uterine dehiscence? So with dehiscence, there's disruption of the uterine muscle, either partial or complete, but the uterine serosa critically remains intact. Most cases of uterine rupture occur intrapartum, following previous caesarean birth or other intracavity uterine surgery, such as a myomectomy. So the incidence or risk of scar rupture after one caesarean birth is 1 in 200 women who spontaneously labour. However, this increases 2 or 3-fold with induction or augmentation of labour. Uterine rupture is rare with an unscarred uterus, affecting only 2 per 10,000 individuals. And a previous uterine rupture has a greater than 5% risk of recurrence. So Embrace in 2017 highlighted that there was a failure to identify the clinical features of uterine rupture in 4 out of 5 women affected, and this led to delays in care. Studies have shown increasing rates of uterine rupture, but it is felt that this may be due to rising caesarean rates, increasing induction or augmentation of labour, and potentially a higher clinical awareness leading to a greater identification of the rupture in the first place. So, looking at the risk of uterine rupture, this first starts with antenatal counselling. The Royal College of Obstetricians and Gynaecologists have a green top guideline on vaginal birth after caesarean birth. And this involves a pro forma when counselling women in clinic about previous caesarean and the mode of birth in this pregnancy. Contraindications to having a vaginal birth after caesarean section or a VBAC is a previous classical caesarean, uterine rupture, or other contraindication to vaginal birth. With a complex uterine scar or 2 or more previous lower segment caesarean births, the woman needs to be reviewed by a senior obstetrician to counsel them appropriately, and they must have access to the surgical notes. Women should birth in a setting where recourse to immediate surgical birth is possible, and this is important to counsel and so that women understand the risk why this is. So if we look at risk factors to do with uterine rupture with a previous caesarean, firstly, a short interdelivery interval, so less than 12 months between caesarean births, and then attempting another vaginal birth would lead to an increased risk of rupture. Having a post-dates pregnancy, fetal macrosomia, though there's not a specific weight on this, maternal age over 40 years, and raised maternal BMI. Also starting with a lower pre-labour Bishop score, and also if there is decreased lower segment myometrial thickness on ultrasound assessment. However, the RCOG guidelines do not recommend routine 3rd trimester screening or ultrasound for these women. If we look at the rare risk of a uterine rupture with an unscarred uterus, this is most classically and most commonly associated with grand multiparity, induction or augmentation of labour involving hyperstimulation or malpresentation, also with obstructed labour, uterine abnormalities, or rarely history of trauma in the pregnancy. So if we look now at the clinical features of uterine rupture, the most common clinical feature is abdominal pain, particularly between contractions, and an abnormal CTG, which is most commonly a bradycardia. There may be evidence of vaginal bleeding, though it could be a concealed bleed in the uterus which would not present with vaginal bleeding. Blood-stained liquor, especially if there's been a change in the colour of the liquor. Hematuria if there's involvement of the bladder, and cessation of previously efficient uterine activity, which has been highlighted particularly in the Embrace report that we don't always recognise this, highlighting the importance of reviewing the partogram and palpating the abdomen carefully for contractions. Loss of station of the presenting part, which again could be found clinically, but also seen on a partogram finding, and change in the abdominal contour or an inability to pick up the fetal heart rate at the old transducer site. It may be, though, that there's only clinical signs of shock due to a concealed hemorrhage with no revealed bleeding, but the woman presenting unwell. So looking at the complications of uterine rupture, we can split this into maternal and perinatal risks. So the most worrying one, obviously, for the mum is mortality, but also a risk of hysterectomy, obstetric hemorrhage, which could be both an antenatal or a postpartum hemorrhage, admission to ITU, and damage to other organs, for example, bladder rupture being the most common. And all of this leading to a longer, more complicated hospital stay. For the baby, there's again risk of perinatal mortality. And the morbidity can include hypoxic ischemic encephalopathy, permanent neurological injury, neonatal acidosis, and low APGARs. If a woman has decided that she would like to have a VBAC, we need to consider their intrapartum care. We may consider to use mechanical methods for induction of labour and avoid prostaglandins, as this increases the risk of rupture. A cautious use of oxytocin with appropriate obstetric review before prescribing this, and birthing or labouring in an obstetric unit with the ability for immediate recourse to caesarean birth if required. One-to-one care with hourly observations and a recommendation of 4 hourly vaginal examinations. In labour, there needs to be continuous electronic fetal monitoring when regular contractions commence, and having an intravenous access in labour so that you have an up-to-date full blood count, group and save, and that you also have the access that may be needed if emergency drugs or fluids need to be given. We'll now run through the algorithm for uterine rupture that's in your prompt handbook, but we'll go through this step by step. So first of all, if you think that there may be a uterine rupture, early recognition is crucial. Stop the oxytocin infusion and get help, either with an emergency buzzer or putting out a 2222 bleep for the obstetric emergency team. If you suspect a uterine rupture, this needs to be a category 1 birth, and you need to escalate earlier to your seniors. So your senior midwife, the most experienced obstetrician and anaesthetist, and early escalation if consultants are not present at the time. You'll also need more staff to support transfer to theatre, as this may be a complex caesarean birth, and a neonatal registrar or more senior to attend the birth. Immediate resuscitation, so using your ABC algorithm. We need to make sure that we have 2 large bore cannulae, that we've taken bloods, including a full blood count, also clotting and cross-matching, at least 4 units. Intravenous fluids should be considered if clinically appropriate, with the most common being prescribed being warmed crystalloid, and maintaining your continuous electronic fetal monitoring until the baby is born. Regarding the anaesthetic choice, there is the choice between a regional or general anaesthetic, and this should be made jointly between your senior anaesthetic and obstetric teams, based on safety of the woman, operative urgency, and maternal condition, and with the inclusion of the woman where possible. If an exploratory laparotomy is required, then a general anaesthetic may be a preferred option because of the potential for increased operating times, major obstetric hemorrhage, and challenging intraoperative pain management beyond a routine caesarean birth. If you feel that there is a uterine rupture, you will need to perform an emergency laparotomy as part of your caesarean birth. Your aim is to expedite birth within 18 minutes, as this has been shown to improve neonatal outcome. So this is slightly quicker than our usual cutoff of 30 minutes for a category 1, and this should be communicated clearly with the team. Neonatal resuscitation with the appropriate team members present, and considering a midline laparotomy for improved surgical access, particularly if you can feel the fetal body parts through the mother's abdomen. Uterine repair is preferred, but if there is an extensive defect, you may need to consider hysterectomy, and this may need to involve the gynecologists if appropriate or as per your guidelines in your hospital. Make sure that you've performed a systematic review of the pelvis, Most commonly, the broad ligament and bladder can be injured, and these need to be carefully reviewed. As with all caesarean births, but particularly important to consider antibiotics, uterotonics, and that you should anticipate that this will be a higher blood loss procedure, leading to a potential major obstetric hemorrhage. Post-operative care after birth of the baby and either repair or hysterectomy of the uterus. We need to consider this carefully as to where this is being performed. So there's a lower threshold to have a maternal critical care setting. Aim to keep mother and baby together where appropriate and to give feeding support if you're able. Thromboprophylaxis and the timing of this, especially in regards to ongoing bleeding or risk of bleeding, needs to be carefully considered. Post-operative analgesia, so with a longer operating time you may have more complex analgesic requirements. Maintaining a urinary catheter, both for monitoring that there's no hematuria, that there's good urine output, and documentation and debrief, which should both be immediate with the woman and her birth partner, but also you may invite the woman back in a couple of months to debrief after such a significant event to reduce the risk of post-traumatic stress disorder and to be able to answer those crucial questions. Finally, completing a clinical incident reporting form. Even if there has not been major blood loss or hysterectomy, a uterine rupture does need to be reported. So up on the screen at the moment is the clinical checklist for uterine rupture, which you could use as a pro forma in your local unit. As you can see, it's summarised all of the crucial aspects of care that we've run through in this presentation, including calling for help, ABC resuscitation, plan for theatre, transfer, and also the post-operative management. It also gives space for you to document any notes in what would likely be a complex case. So, I hope that this presentation has been helpful in helping us understand that uterine rupture is uncommon but life-threatening, that previous caesarean birth is the most common but not only underlying cause, to appreciate the importance of prompt identification, early escalation, and the multi-professional team, to consider expediting the birth of the baby ideally within 18 minutes, and to understand that complications include hemorrhagic shock, perinatal morbidity, and complex postnatal care. Thank you.